So first, I have the honor to present Dr. Jessica Lloyd. Dr. Jessica Lloyd is an assistant clinical professor of the pediatrics in Division of Pediatric Hospital Medicine and an associate program director for the UCLA Pediatric Residency Program. She's interested in resident well-being and promoting residency resiliency, and is involved in multiple programs within the Department of Pediatrics to improve resident wellness. Dr. Lloyd is also the co-principal investigator on a national pediatric resident burnout and resilience study throughout the Association of Pediatric Program Directors. So please join me in welcoming.
Thank you so much for having me. So a little bit of background on how I got interested really in physician wellness was my own experiences. So I trained here in pediatric residency. I did a chief residency year, and then I went on to do a pediatric critical care fellowship here. And I struggled a lot with the emotional toll that being a pediatric intensivist took on me. And I didn't really realize at the time as I was going through training and then afterwards as a new attending in the ICU that the feelings that I was having, a lot of them were PTSD feelings, and going through seeing patients, seeing children die, experiencing that with the family and kind of moving on was really challenging. And you know, I have many different patients that I recall where, you know, during a patient death, for example, I would remember the death so vividly, and I still do, and remember what the parents were saying to the child at the time, what they were doing with the child at the time of death. And it stuck with me to the point where it was, you know, I was having trouble sleeping. I was, you know, trying to do all the things that I was supposed to do to be well. I was running, and I was like, you know, trying to take really good care of myself, but it was still, I was just experiencing this post-traumatic stress, and I just didn't realize it at the time, what it was. And I was lucky enough to get, to work with Dr. Brenda Birch and Dr. Mioto on a project to promote resilience, and I'm going to talk a little bit about it, but that's sort of the background, was that I got really interested in how can I continue to take care of my patients the way that I want to, but still be well and not have these kind of like recurrent memories of these traumatic events. And that's to say, I absolutely loved my job, and I still do. But it's been challenging for me, kind of trying to learn and to grow. How can I continue to take care of these patients to the best of my ability, while at the same time, you know, be healthy. So after finishing critical care fellowship, I went on to be a critical care attending, and actually right now I'm taking a little break from that, and I'm doing I'm a pediatric hospitalist at this point. And in addition, I'm one of the associate program directors for the pediatric residency program here. And a little overview of our program. So we have 95 pediatric residents that rotate through 4 different main training sites. It's a 3-year program, and our main training sites are here in Ronald Reagan in Westwood, Santa Monica, Cedars-Sinai, and All of You Medical Center. We have a very high acuity of our patients, especially here in Westwood. Incredibly sick children that are transported from all over the West Coast to be treated here at our hospital. I became very interested in resident well-being when I became one of the associate program directors, and this has become one of my passions. And so we know that pediatric residents are actually at a higher risk for burnout and depression compared to the general population. The rates are anywhere between 40 to even 75%, and rates of depression of up to 20%. And there is some question of if depression and burnout are even different, or if they're actually pretty similar. But in any case, depressed or burnt out residents report poorer health and higher medical error rates than those who are not burnt out or depressed. And burnout is associated with sleep deprivation, which seems pretty obvious. It's associated, as we already talked about, with higher levels of job dissatisfaction, more reported medical errors, negative attitudes towards patients, and patient dissatisfaction as well. In addition, on a personal level, residents who are burnt out have more failed relationships, they're more depressed, more likely to abuse alcohol and to have suicidal ideation. We also know that, like I think I was at the time, there is this idea of the second victim syndrome, which is hospital workers who are traumatized after adverse patient events. And we should be better about identifying these second victims and helping them. And so I was lucky enough, like I said, to work with Dr. Mioto and Dr. Brenda Birch in the Department of Psychiatry here to promote resilience amongst our pediatric residents. So resilience is the ability to respond to stress in a healthy way. So it's like the ability to bounce back. And what we did was we adapted what's called the Focus Resiliency Program, which was an evidence-based, trauma-informed resilience skills training program that is delivered to active duty military and their families. And it was actually developed here in conjunction with here and Harvard. And it's been used in over 750,000, with over 750,000 participants. And has been shown to be effective at reducing distress symptoms and enhancing positive coping in adults and youth. And so what we did was we adapted this curriculum for the needs of pediatric residents. And we delivered it in 6 one-hour modules at each of our 4 training sites. Because of our very confusing resident schedule with 4 different sites and the duty hours, et cetera, the average number of sessions attended was about 2.5. And we had almost 60 residents complete at least one of our surveys. And at each session, we had a pediatrician and a mental health professional. We went through the following skills training, so goal setting, narratives, emotional regulation, and communication with angry families or angry parents, and then depression, trauma, and personal toolbox. So each resident creating what helps them when they're feeling stressed, when they're feeling depressed. We also had, we videotaped some of our faculty talking about times when they were depressed, talking about times when they felt sadness over a patient death and how they coped, talking about times when they disagreed with the decisions that were being made about the patient. Maybe they disagreed with their attending and how they coped with that and what they did. So we looked at a bunch of different outcome measures, and basically what we found was that we were able to change beliefs and able to change how residents felt like they would be able to cope with patient deaths. So we found significant changes in the following areas. So my attendings seem unaffected by the death of a patient. They realized that their attendings were affected. More residents were likely to say, I know it helps me when I disagree with the medical decision-making of an attending or family. I know how to recognize signs of stress or trauma in others, and I know evidence-based approaches to assisting others with signs of stress and trauma. And nearly significant was I know what I can do to help myself with my own grief after the loss of a patient. Over 80% of residents said that it changed how they will respond to patient-related grief and trauma. Now, what we were attempting to do was not to see if we could affect burnout in an 8-week time period. What we need to do is have them use the skills that we taught them, and then our plan is eventually to reevaluate with the burnout inventory scale and with the brief resilience scale. But in the interim, we were able to change beliefs. So our baseline burnout data that we reported was about a third reported high levels of emotional exhaustion and half reported high or moderate levels of depersonalization. What was nice was that about 75% reported high feelings of work-related personal accomplishment, which was nice because that's protective against burnout. And so what we really aim to do was give residents skills to cope, which can then ideally lead them to be more resilient, which we know resilience can protect against burnout. And so that was our goal, and eventually, like I said, we will try to see if over time, if the residents, A, are using these skills that we taught them, and B, if it does protect against burnout. Our hypothesis is that it will. And There's some other interventions that we have done to help with resident wellness in the pediatric residency. We have debrief sessions after patient deaths. We have informal check-ins where myself or some of the other associate program directors will go to the ICU after we hear of a traumatic patient death and check in with our residents, see how they're doing. We attempted to do Ballant groups, which are sort of processing groups. The residents, that did not go over very well with our residents. They didn't really enjoy those. We tried having a distress on-call pager. I manned a pager that was 24/7. If you're feeling distressed, page me. I got 0 pages. So that didn't work. And then we'd have other nice things like resident retreats twice a year where we leave campus and try to get some fresh air. And then we try to take feedback on their schedule, so trying to give them more time off. Also understanding they have a certain amount they need to learn in that time period, but trying to give them a little bit more weekends off, and trying also to unload some of the clerical burden that the residents work. We have undergraduate students that help with that. We are part of this national pediatric residency burnout resilience study with 41 pediatric residency programs. That's the website. Feel free to check it out. And we are, the first phase has just finished, which is sort of defining burnout and resilience amongst pediatric trainees in 41 programs. So thank you all.